Hello, my name is Dr. Susan O'Brien, and I'm the Ashbel Smith Professor in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. I'm often asked, what are the most recent updates to the NCCN Guidelines for CML? The NCCN Guidelines were recently updated, and one of the important things was an initial evaluation time point at 3 months. The options for starting therapy still include Imatinib, which is a very tried and true and effective therapy in many people, but as you also know, Imatinib and Nilotinib have FDA approval based on randomized trials as alternate choices in frontline therapy. Some people prefer the second generation, as we call them, TKIs, because the short-term endpoints that you can achieve tend to be achieved more quickly in terms of response, both cytogenetic and molecular. But Imatinib is still a reasonable therapy. What we want to do when we're looking at the 3-month time point is come in early, because there's a small percentage of patients, more so on Imatinib than the other TKIs, where we have sudden transformations. So early sudden transformations to accelerated phase or blast crisis. The problem is, once a patient transforms to a blast crisis, as you know, the prognosis is very poor. So one of the reasons to have an early time point is to try and intervene if the 3-month time point is not where we want it to be. And what is that? What we ask is for cytogenetics to show at least a major cytogenetic response, so the Philadelphia chromosome reduced to below 35% in the metaphases. Or if we're using PCR, and importantly that PCR needs to be standardized to the international index, and that PCR is greater than 10%, we know from looking retrospectively at the original trials that these are patients who are less likely to have a good outcome and who still have good survival, mind you, but have a shorter survival if they don't reach those time points. And so there, when you get there, if you're not at that time point, you can think of something else to do. Now, that is one of the limitations of the changes in the NCCN guidelines, which is that there's a lot of data that that's a reasonable endpoint in saying that these people are not going to do as well. One of the problems is actually having data to say, well, I know if I change from treatment A to treatment B based on not achieving the response I want at 3 months, that change will impact the long-term outcome. And that's where we have some trials going on now, but very little data. So that could reasonably be considered one of the criticisms to changing the treatment, which is why we also offer staying on a second-generation TKI rather than switching and following up at 6 months as another possibility. But we give the physician several choices there, and certainly a heads up that even if you're not going to switch therapy, that's a patient you may be more concerned about and want to be much more careful with your monitoring.